everybody. So today's topic of discussion is basic electrophysiological approach to supraventricular tachycardia. So this is one topic which is very intimidating for fellows who are doing DM and DNB in cardiology, and often they try to skip this topic. So today I will try to make this topic simple for you guys so that you can at least learn the basics, and then when you go to the EP lab, you feel better equipped to understand things. So bird's eye view to today's presentation. So first we'll talk about what we actually want to do with EP study. We need to know the differential diagnosis of this SVT on the ECG. Then we'll have a short primer to EP traces so that we start understanding what information is there in the EP trace and how we have to interpret. And lastly, then we'll go into the approach to the SVT in the EP lab. And we'll discuss that in three headings: baseline characteristics during normal sinus rhythm, tachycardia characteristics, what happens during tachycardia, and what maneuvers we can do during tachycardia for the confirmation of diagnosis. So let's start. So first is ECG approach, the differential diagnosis. So we all know that supraventricular tachycardias are narrow complex tachycardias which can be regular and irregular. Irregular tachycardias are irregular is atrial fibrillation or atrial flutter with variable conduction, and sometimes we can have atrial tachycardias which are focal with variable conduction and multifocal atrial tachycardias. So these are the irregular tachycardias, and often we are not doing EP studies for irregular tachycardias. So what is area of interest for today is the regular tachycardias. And when we talk about regular narrow complex tachycardias, so the differential diagnosis is the AVNRT, the AVRT, focal atrial tachycardia, atrial flutter with 1:1 or 2:1 conduction, or sinus tachycardia. So for purpose of simplicity, sinus tachycardia is out since we are not doing EP study for those tachycardias, and atrial tachycardias and atrial flutter would be clubbed together because both behave similarly during EP as atrial tachycardia. So our predominant discussion is AVNRT, AVRT and atrial tachycardia. So just to be sure about what's happening in the tachycardia, just a brief introduction to the circuit. So this on the left side is the atrioventricular nodal reventrant tachycardia, which is also called as the AVNRT. So it is a circuit which is between the slow pathway and the fast pathway, as we all know them. But the slow pathway and fast pathway are actually atrio-nodal inputs to the AV node. And if we see the circuit, the green line which we see, that it is going down the slow pathway and coming up the fast pathway and then exiting towards the atria, and one end is exiting towards the ventricle. So the activation, which is the two green arrows, one is towards the atria and the ventricle, they are occurring together in parallel and not in series. So what happened in the circuit is moving, the activation of the ventricle and atria are occurring simultaneously. That's why the atrial activation is occurring just upon the ventricular activation. The other thing important in this case is that the circuit is completely suprahisian. If you see the His bundle, the conduction system and the ventricle, they are not a part of the circuit. So it is possible that the tachycardia goes on when there is an HV block and ventricular conduction is not happening. So the second tachycardia is the focal atrial tachycardia. It arises from a focus from the atrium as depicted in the figure with a blue dot, and from this the atrial impulse starts, and it frequently comes to make a tachycardia. There is no part of the conduction system or the ventricle in the circuit. This tachycardia, which is arising from this one single point, goes towards the conduction system, captures and goes to the ventricle. Even if it gets blocked in the conduction system, there can be an AV block and the atrial tachycardia can continue. The other two tachycardias are the AVRTs, which can be of two types: the ORT, orthodromic re-entry, or the antidromic re-entry. In the orthodromic re-entry, the conduction system is captured antigradely, while the accessory pathway is captured retrogradely, while the reverse is true for antidromic tachycardia. Importantly, this circuit, the atria and the ventricle are activated in series, one after the other. They are not activated simultaneously. So it is not possible to get atrial activation simultaneous with ventricular activation in an AVRT. The other important feature is that the conduction system and the ventricle are a part of the circuit. So if a conduction system block happens, the tachycardia has to stop. So if the tachycardia continues even after conduction system block, it rules out AVRT. So when we look at the ECG, we have short RP tachycardias and long RP tachycardias. Is it short RP or long RP? It depends on the comparison of the RP interval to the RR interval as depicted in the figure. If the RP interval is less than the PR interval or RP interval is less than 50% of the RR interval, it is a short RP tachycardia. The most important diagnosis for a short RP tachycardia are AVNRT, AVRT and atrial tachycardia. While when we are talking about a long RP tachycardia, where the RP interval is more than 50% of the RR interval, the first diagnosis to your mind should be atrial tachycardia. The other two uncommon diagnosis will be atypical AVNRT and PJRT, which is mediated through an atypical accessory pathway. Now, starting with the primer to EP traces. So, this is one of the most intimidating parts for all of us. So, what we do in EP study is place multiple catheters inside the heart to record electrical activation of different regions of the heart. So, this is a usual EP study where we place 4 catheters, especially in an SVT study. So, one catheter is in the HRA, the high right atrium. It is placed near the SVT-CRA junction. It is near the sinus node. Another catheter is placed near the His bundle, which is along the superior septum. Another catheter goes inside the coronary sinus, which is placed along the mitral annulus in the coronary sinus. This is usually a decapolar multipolar catheter, and this catheter records atrial signals from the coronary sinus along the left AV groove, while the HRA records atrial signals from the high right atrium from near the SVT-CRA junction. The His bundle catheters records all the 3 signals A, H, V. This is very important to have His signal for us because it gives a lot of information. And finally, the 4th catheter is in the RV apex, as it can be seen in the RAO view clearly. So, RAO view helps us to decide what's there in the RA versus RV, while the LAO view opens up the mitral and the tricuspid annulus and helps us to decide is the catheter going towards the left side as seen the CS catheter going towards the posterior border of the heart, or is it staying near the septum or towards the right side as the HRA. So, in EP study, we are not talking about rates of 100, 120, 150. What we talk about is cycle lengths. So, it is important to remember that we talk about cycle lengths in EP study, and cycle length is calculated by a formula which is 60,000 divided by rate. So, a rate of 150 beats per minute will give you a cycle length of 400 milliseconds. So, this is a basic EP trace. So, all EP traces have 3 to 4 ECG leads on the top. In this ECG trace, we have 1 AVF and V1. So, it is important to note that it may appear white to you, but this is not 25 millimeter per second as a normal routine ECG is. EP traces are recorded usually at 100 millimeter per second or more. So, this is a trace at 100 millimeter per second. So, first 3 are the ECG traces. This is a narrow QRS on the 100 millimeter trace. And then we have a right ventricular catheter which is recording the RV activation at the apex, which gives a EGM which is simultaneous with the QRS or the ventricular EGM. So, a very important way to look at the EP trace is to first look at the ECG, since all of you know the ECG, and see what waves are coming with the P waves and what waves are coming with the QRS complexes. Any wave which is coming with the QRS complexes is likely to be ventricular, and the waves which are coming with the P waves are likely to be the atrium. So, the high right atrium records a wave which is simultaneous with the P wave, in fact at the start of the P wave, because the impulse is beginning there only near the sinus node. While the His bundle electrogram records all the 3 atria, His and ventricular EGM. His EGM is a very sharp high frequency signal which is found in between the P and the QRS. The coronary sinus catheter records predominantly sharp spiky atrial signals with the P wave. However, a small deflection of ventricular EGM may be seen because the coronary sinus catheter is along the annulus. Especially if the distal tip is entered into a tributary of the coronary sinus which is along the ventricular, you may get big ventricular deflections in the distal CS channels, which are the CS1, 2 and CS3, 4. So, what we measure is the cycle length which can be measured from one EGM to another EGM. In this trace, it has been measured from HRA EGM to HRA EGM, which gives us the cycle length. Then we can measure the PA interval, which is from the beginning of the P wave to the atrial electrogram, the AH interval, which is from the atrial electrogram to the His electrogram, the HV interval, which is measured from the beginning of the His electrogram to the beginning of the QRS on the surface ECG, the QRS width and also the QT interval. So, these are the major intervals which we measure in an EP study. And what about the pacing protocols? So there are two important modes of pacing. One is the burst pacing, another is an extra stimulus testing. So in burst pacing, we give a stimulus at a fixed pacing cycle length consistently. Like we can give a burst pacing at 400 millisecond cycle length, in which we just keep on giving multiple stimuli at a cycle length of 400 milliseconds. So in burst pacing, we say the pacing is going on like S1, 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 S1. So if the patient is in his baseline rhythm and we start pacing, so the first impulse which is being delivered is called as S1, and if at that same cycle length the impulse is being delivered, it is continued to call S1. When we give an extra stimulus testing, in this what we do is we give a basal drive train of 5 to 8 beats at a fixed cycle length. This helps us to set the refractory periods in a manner in which we can test them. Because the refractory period is dependent on the previous cycle lengths, we have to give a baseline pacing cycle length so that we can give an extra stimulus and test the consistency of the extra stimulus response. So in this we give a basal drive train of 5 to 8 beats of S1 stimulus, and then we give an extra beat which is the S2, which is at a different cycle length, mostly shorter cycle length. This is called an extra stimulus, and we check what happens after the extra stimulus. This is called as the extra stimulus testing. Extra stimulus can be 1, 2 or 3. The first extra stimulus is called S2. If we give 2, it is called S2 and S3. If we give 3, it is called S2, S3, S4. This can be of variable cycle lengths, and we can test the conduction system or the properties of the electrical properties of the heart with giving different extra stimuli. So this is an example of extra stimulus testing. This pacing is happening from the high right atrium. As you can see the pacing spike there. So that pacing spike creates an S1, begins an atrial activation which gets conducted down to the ventricle. Another S1, this is the end of the drive train. 5 to 8 beats have been given before on the left side of the trace, which we are not seeing here. And finally, we give an extra stimulus S2, which is obviously happening at a shorter cycle length. We all know that AV node has decremental properties. So if we are pacing faster at the atrium, AV node will decrement, meaning that there would be a longer conduction time from going from atria to ventricle, which is seen as the increase in the interval of AH interval. So what we see with an with a baseline pacing at S1, we are having an interval A1, H1. And when we give an extra stimulus S2, this interval prolongs to A to H2. So this is a typical decremental property of the AV node, which is being tested by giving extra stimulus. And beyond, when we keep on making this extra stimulus shorter, so in the previous figure, this extra stimulus was given with a basal cycle length of 500 millisecond and extra stimulus cycle length of 300 millisecond. This beat had conducted. But in this figure, when we give an extra stimulus at 280 millisecond, the beat gets blocked, which means now the AV node has become refractory at a cycle length of 280 millisecond. Thus, it has become blocked here. So this is the effective refractory period of the AV node. Another important concept in EP study is concentric atrial activation and eccentric atrial activation. What we see here is the pattern of atrial activation which is happening when we pace the ventricle. So in this figure, if we see the largest pacing spike is in the RV apex. So we are pacing from the RV apex, and when we pace from the RV apex, we get an LBBB kind of a pattern which can be seen as a QS pattern in the lead V2 on the surface ECG. And when we pace the ventricle, the impulse captures the conduction system and travels back to the atrium and activates the atrium. So when the atrial activation is happening after ventricular pacing, if it is happening through the conduction system, it will reach through the His bundle, through the AV node into the atrium. So the first exit in the atrium will be near the His bundle. Then it will travel all over the atrium, goes toward the proximal coronary sinus, and since high right atrium is away from the AV node, it would be the last to reach. So this pattern of activation, atrial activation, which is seen on intracardiac EGM, where the first atrial activation is happening on the His bundle catheter, then in the proximal coronary sinus, the CS910, which goes distally towards the distal coronary sinus, CS12, and lastly in the HRA, this pattern of activation is called as a concentric atrial activation, where the first activation happens at His bundle, the next atrial activation at proximal coronary sinus, and last atrial activation at high right atrium. So this is the basic concept, that it comes back through the AV node and the His bundle and the AV node, exit towards the superior part of the septum, giving an earliest atrial impulse at the His bundle. then at the proximal coronary sinus, which travel both ways, right and left, towards the mitral annulus also, recording distal activation in the CS, and lastly high right atrium. While if we have an eccentric atrial activation, so if we have an accessory pathway, so supposedly there is a left lateral pathway along the lateral mitral annulus. So if we are pacing the ventricle now, this pacing impulse will travel to the atrium through this accessory pathway along the lateral mitral annulus. And when it does so, the earliest activation happens along the lateral mitral annulus. In this case, if we can see that the pacing impulse has traveled with the atrial activation, which is first at the distal coronary sinus, then at the proximal coronary sinus, then at the His bundle, and lastly at the high right atrium. So such an activation is called eccentric atrial activation, which suggests that the activation is not occurring through the usual conduction system and there is a presence of an accessory pathway. So basic approach to SVT. So we have to differentiate. What we are trying to differentiate is between the differential diagnosis of the SVT, which we have seen on the clinical ECG. So what we see in the clinical ECG is a short RP tachycardia and a long RP tachycardia. We can have a judgment that this is AVNRT or AVRT based on the ECG, but we cannot be 100% sure. To confirm a diagnosis, we need to do an EP study, and that's what we are going to discuss today. So how do we differentiate between the two? The most important thing is that we try to differentiate between the conduction properties of an AV nodal conduction axis versus a typical accessory pathway. So these are very important points we need to know. So AV nodal conduction axis has a decremental conduction. So faster pacing will cause a delay in the AV node, while a typical accessory pathway has non-decremental and fast conduction. So even if you pace faster, the AV delay will not change. It will keep on going at the same conduction speed through the accessory pathway. The second thing is that when we are pacing the atrium and the path impulse is going through the AV nodal conduction axis, it will always give a narrow QRS or sometimes maybe an aberrant QRS due to high rate. In that aberrant QRS will be right bundle, will have a typical right bundle branch block pattern or a left bundle branch block pattern, and the HV interval remain constant and positive. While in a typical accessory pathway, when we are pacing the atrium and the impulse is going through the accessory pathway, it will give a broad pre-excited QRS, which will be seen on a ECG and if we pace faster, we get a maximal pre-excitation. When we pace faster and faster, His bundle activation gets delayed. So the AH is getting delayed. However, the AV is fixed through the accessory pathway, which lead to a shortening of the HV interval and broadening of the QRS. And regarding the retrograde properties, AV nodal conduction axis will give a concentric atrial activation, while retrograde accessory pathway will give an eccentric atrial activation, except in the cases where the accessory pathway itself is Parahisian, thus giving an earliest activation at the His bundle. So we have to begin our EP study in the lab with antegrade pacing, antegrade conduction properties, atrial pacing, and retrograde conduction properties, the ventricular pacing. So this is what we begin our EP study with. We check the baseline conduction properties and check if it is happening through the AV node or is there any presence of accessory pathway. So we'll discuss the pacing maneuvers at baseline one by one, the ventricular pacing, the atrial pacing, and then the pattern of induction of tachycardia. So coming to ventricular pacing, it gives information regarding the retrograde conduction, whether the retrograde conduction is concentric and whether it is decremental versus non-decremental. Then we have to check whether it is eccentric or if it is absent. If the retrograde VA conduction is absent, it is very difficult for a tachycardia which is re-entrant between the atrium and the ventricle like AVRT or AVNRT to happen. So absent VA conduction on V pacing means that the likelihood of the tachycardia is that it is more likely to be an atrial tachycardia. But in sometimes the patient may have a high vagal tone, thus VA conduction may be absent at baseline. So we have to always check with isoprenaline, and if it comes back with isoprenaline, in these cases it is still like possibility of AVNRT is still there. So this is again the same concept which we have discussed. This is an concentric atrial activation on V pacing, and what we are looking at here is extra stimulus testing. So baseline train at 600 milliseconds has been given S1, and then an extra stimulus is given through the RV pacing at 360 milliseconds, and we are checking how the VA conduction is happening. So the earliest atrial activation is recorded at the His bundle, then travels through the coronary sinus and lastly at the higher right atrium. This is concentric atrial activation. And when we give a shorter extra stimulus at 260 millisecond, what we see, the conduction is happening in the same pattern. It is still concentric, but interestingly, if we see the gap between the ventricular pacing spike, the S2 and the atrial activation, now this is prolonged. So VA conduction is prolonged with a shorter extra stimulus. This is clearly decremental conduction. So concentric and decremental conduction are the properties that this conduction is happening through the AV node or through the usual conduction system of the heart, and axillary pathway is absent. While if we sometimes what happen, the conduction pattern might change also. So in the baseline S1 if we are seeing, the conduction is still concentric, while the extra stimulus given at S2 of 380 millisecond, atrial conduction becomes eccentric with the earliest atrial activation at the distal coronary sinus. So this happens because there is an axillary pathway and conduction is happening through both the AV node and the axillary pathway, but when we give an extra stimulus, either it gets blocked in the AV node or it gets too much decremented and prolonged in the AV node. Thus, the activation is now happening predominantly through the axillary pathway, giving us an eccentric atrial conduction. So this testing gives us an idea if there is a presence of an axillary pathway in the retrograde direction or not. So these are the diagrammatic representation where we are giving RV pacing. It is going through both AV node and the axillary pathway, predominantly happening through the AV node, thus giving concentric activation. While when we are giving it a shorter cycle length, it gets blocked in the AV node and it's traveling through the axillary pathway, giving an eccentric atrial activation. The second maneuver is the Parahis pacing. The Parahisian pacing, what we are trying to do is, we are trying to pace with the His catheter near the His bundle. And if we are pacing at a higher output, we might capture the His bundle. If we are pacing at a lower output, we might not capture the His bundle. So when we capture the His bundle, we get a narrow QRS with the pacing. While when we are not able to capture the His bundle, we get a broad QRS after a ventricular pacing. So this is important to note because it helps us to distinguish between conduction of between the presence of an axillary pathway versus absence of an axillary pathway. So what we see in this is we compare the response of VA conduction when the His bundle is captured and when the His bundle is not captured. So whether the His bundle is captured or not captured is judged by the width of the QRS on the surface ECG of the ventricular paced QRS. So when the ventricular paced QRS is narrow, the His bundle has been captured. When the ventricular paced QRS is broad, the His bundle has not been captured. So imagine if there is only AV nodal conduction and there is no accessory pathway and we capture the His bundle. So since we have capturing the His bundle, so the impulse can travel back to the AV node very fast and can capture the atrium, thus giving us a shorter VA interval. But when we are not capturing the His bundle and we are only capturing the local myocardium in the basal region, now this part of the His bundle is insulated, so the impulse cannot enter the His bundle from this part. So the impulse has to travel down towards more apical myocardium where there are junctions between the Purkinje fibers and the myocardium. Then the impulse penetrates back into the right bundle, travels back through the His bundle into the AV node. So now this impulse has to take a longer route, thus it takes more time to reach the atrium. Thus the VA interval will get prolonged. So if we see, the stimulus VA interval is measured from the stimulus to the atrial activation on the His channel. So when we see on the nodal response, the SA interval changes. It was 190 millisecond in this example when the QRS was narrow and 290 milliseconds when the QRS was broad. This is called as a nodal response, which means there is absence of axillary pathway. While extranodal response, in which an axillary pathway is present. So we all know the axillary pathway are always near the annulus. So they are basal pathways. So now we are pacing near the His bundle. So we are pacing basally near the annulus. So when we pace here, whether there is His bundle capture or not, the impulse has an access to go through the axillary pathway immediately into the ventricle, into the atrium. So irrespective of His capture or no capture depicted by the narrow and the wide QRS on the surface ECG, the SA interval remains the same. And this is a depiction of the presence of an axillary pathway and an extranodal response of Parahisian pacing. So this maneuver at baseline helps to differentiate between the presence and absence of an axillary pathway. This maneuver is not as simple as this, but this is the most basic thing about this maneuver which you should know at this level. There are more intricacies to this maneuver. I am not going to discuss that in detail. It is not possible to cover everything in this 1 hour. But this is the basic principle of the Parahisian pacing, and this is an example. So here the pacing is happening with the his distal channel. We are pacing from the his catheter, and the first 2 impulses are broad QRS as seen on the upper 3 leads, and the last 2 impulses are narrow QRS. Clearly there is his capture in the last 2 impulses. And when we measure the VA, the stimulus to A interval, on the broad QRS it is 202 milliseconds, and on the narrow QRS it is 154 milliseconds, which suggests that this is a nodal response since it is dependent on the his capture. While this is another example, again the first 2 QRS complexes after the stimulus capture are no his capture since they are very broad, while the third beat is a his capture giving a narrow QRS, and what we see, the stimulus to atrial interval remains constant at 105 milliseconds with no change in the atrial activation. So this response, when we are seeing with change in the QRS morphology, it suggests that there is an axillary pathway and the conduction is not dependent on the his capture by our pacing stimulus. So there can be 7 types of Parahisian pacing responses. This is very complex. I cannot discuss everything in this lecture. People interested can go deeper and look into it. Another maneuver is differential RV pacing. This is very similar to Parahis pacing in terms of response. That we are once pacing at RV apex with a particular cycle length, then we are pacing at RV base at the same cycle length near the annulus. So what it does is, so when we are pacing at the RV apex, so the impulse has to travel back to the annulus and then capture the axillary pathway and reach the atrium. Thus it takes longer as compared to the RV base, where it can directly capture the axillary pathway and reach the atrium earlier. So RV base pacing, the VA interval will be shorter than RV apex pacing in presence of an axillary pathway. While in the absence of an axillary pathway, where we have to capture the conduction system, so RV apex has an access to the conduction system earlier, since the retrograde conduction happens at the Purkinje myocardial junction, which is more distally, and then it travels back to the right bundle and the his bundle. While when we pace at the RV base, first the impulse has to travel down towards the apex, then capture the conduction system and travel back up. So it takes more time in the presence of a conduction system only conduction and absence of a pathway. Thus, when we compare VA interval from the basal pacing minus VA interval from the apical pacing, it will always be more in an absence of an axillary pathway, which is the group B in this figure, and it would be less in presence of an axillary pathway, which is the group A in this patient. So VA RV apex less than VA RV base suggests that there is absence of septal bypass tract, while VA RV apex more than VA RV base suggests there is a presence of bypass tract. This is again an example where we are measuring the VA interval from RV apex pacing and RV inflow pacing. So VA interval from RV apex pacing here is 320 millisecond, and VA interval from RV base inflow pacing is 250 millisecond. This clearly suggests the presence of an axillary pathway, since RV inflow VA is shorter than RV apex VA. Now coming to the atrial pacing maneuvers at baseline. So we have to do incremental pacing, which is burst pacing at increasing rate. So what is incremental pacing? That we give pacing cycle length at 400 millisecond, then gradually shorten to 390, 380, 370 after every 2 to 3 beats. So when this happens, if the conduction is happening only through the AV node, it will keep on decrementing. If the conduction is in the presence of an axillary pathway, what is happening? The conduction is happening through both axillary pathway and the AV node. So at a longer cycle length, when we start to pace, the conduction is going through the fast AV node and also the axillary pathway with major contribution through the AV node. But when we pace faster and faster, there is decrement in the AV node, but there is no decrement in the pathway. So more contribution through the pathway and less contribution through the AV node. Thus, more and more pre-excitation with incremental pacing can be noted in the case of a WPW syndrome. So this was a case of a WPW syndrome patient where the baseline ECG had very minimal pre-excitation, which was suggested by R more than S in V1 interval, which can be seen on the right side of the trace. But when we pace the atria, it becomes maximally pre-excited, and this maximal pre-excitation can be seen in the middle of the trace, where it has become very broad QRS, pre-excited QRS with a predominantly R pattern in monophasic R pattern in V1 with a pseudo delta at the beginning. So this is clear-cut pre-excitation from a left lateral pathway, 1 AVL negative, 2-3 AVF positive, and lead 1 positive, V1 positive. So what we have to notice with atrial pacing is also we test with the extra stimulus. So what's happening here? We are giving a basal train S1, 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 the first 3 pacing stimulus through the coronary sinus catheter, this time CS910, and the 4th beat when we give an extra stimulus at a shorter cycle length. In this, it is written at the top of the figure, the basal cycle length is 400 and the extra stimulus is 240. So when we give an extra stimulus at 240, we can see the QRS becomes broader, which suggests that there has been decrement in the AV node with more conduction through the axillary pathway, thus leading to a broader QRS and more pre-excitation. But what we notice here, that the AV delay from the pacing spike and the atrial capture to the beginning of the QRS on the surface ECG remains constant, thus suggesting that there is no decrement happening through the axillary pathway, and it's a typical axillary pathway which is present there. Another thing important to note is dual AV nodal physiology. So this is noted with an extra stimulus pathway. So what we know about dual AV nodal physiology is that AV node has 2 parts, may have 2 parts, which is the slow pathway and the fast pathway, which may differ in their electrical conduction properties. So slow pathway is slower and takes a longer time to conduct down to the ventricle, while the fast pathway is faster. So how slow, how fast? So basically there is a difference of at least 50 milliseconds of conduction between the two, and the slow pathway is defined when the AH conduction is happening of more than 200 milliseconds. So that is defined as slow pathway. So when we are giving extra stimulus testing, so usually what is known about these 2 pathways is that the slow pathway has a shorter refractory period, while the fast pathway has a longer refractory period. So what happens is, if we give progressively shorter extra stimuli, so there would it would happen once that it would get blocked into the fast pathway because it has longer refractory period, while it still gets conducted down the slow pathway only because it has a shorter refractory period. So when the conduction was happening through both slow and fast pathway, the AV delay was shorter, and when suddenly the conduction gets blocked into the fast pathway and gets only conducted through the slow pathway, the conduction prolonged significantly suddenly. This sudden prolongation of conduction denotes that there has been shift of conduction from fast pathway to slow pathway, which suggests that there is a dual AV nodal pathways, the slow pathway and the fast pathway, suggesting a dual AV nodal physiology. This physiology suggests the possibility of AVNRT, and it is very commonly found in AVNRT cases. Important to remember is that both fast pathways and slow pathway independently have decremental properties. So if you are pacing faster, small decrements will happen even when conduction is happening only through the fast pathway or only through the slow pathway or both. But when there is a sudden jump of conduction, that is called as that depicts the dual AV nodal physiology, and that is called as an AH jump. So how do we measure an AH jump? How do we define an AH jump? AH jump is defined as an increase in AH interval by more than 50 milliseconds with a decrement in pacing cycle length of only 10 milliseconds. So in this example, in the first trace, we are giving a basal cycle length of 600 milliseconds. We give an extra stimulus at 360 milliseconds. So what we see with the extra stimulus of 360 milliseconds, there is an A2H2 interval of 285 milliseconds. So to note here is that A1H1 with the basal cycle length is 115, and with an extra stimulus of 360, A2H2 is 285. So now this is not AH jump. There is the decrement which will happen with decreasing pacing stimulus. So this is the usual decrement. But now we shorten the extra stimulus by 10 milliseconds. Now in the second figure, we give an extra stimulus S2 at 350 milliseconds and now measure the A2H2. Now this A2H2 jumps to 370 milliseconds. So at 360 milliseconds, A2H2 was 285 milliseconds. And now A2H2 at 350 milliseconds is 370 milliseconds, which means that there has been a jump of 85 milliseconds with 10 millisecond shortening of the extra stimulus, thus depicting that this is called as an AH jump. Now, initiation of tachycardia. If what happens, the conduction blocks in the fast pathway, there is an AH jump, it goes down to the slow pathway. Sometimes the fast pathway is recovered because of the slow conduction to the slow pathway, and once this pathway is recovered, it is available for a retrograde conduction to the atrium. Giving a retrograde conduction to the atrium will lead to a retrograde atrial activation, which is called an echo beat if the tachycardia does not continue there. So in this figure, we have given extra stimulus at 550 millisecond. It prolongs the AH interval, causes an AH jump, and then leads to a retrograde atrial activation, which is seen on the coronary sinus catheter, which is happening simultaneously with the ventricular activation as the atrial activation is occurring along the line of the QRS. So this atrial activation, which is occurring retrogradely, is an echo beat which is happening from the circuit. So this echo beat, we are sure that this is retrograde because high right atrium is late and the earliest activation is near the His bundle and the proximal coronary sinus. So this may lead to initiation of an AV-NRT, where the AH jump leads to initiation of the tachycardia, and now each atrial activation which is happening along in the atrial activation is most prominently seen in the coronary sinus catheter, with sharp atrial activation recorded along the coronary sinus. So these activations are now happening along the QRS complexes. Thus, we know that this is an A1V tachycardia which is started with an AH jump. So this is diagnostic of AV-NRT. So this AV prolongation initiates AV-NRT with an AH jump, while a simple AV prolongation, if it is too prolonged, allows the axillary pathway to recover in a retrograde direction, and it can initiate orthodromic AV-NRT also. So here in this case, what happens with an atrial extra stimulus? So what we see in the baseline, the QRS is wide when we are giving a basal train, and when we give an atrial extra stimulus, this gets blocked in the axillary pathway, thus giving a narrow QRS. And when it goes through the AV node, it is getting blocked in the axillary pathway. The axillary pathway gets recovered in the retrograde direction and allows a retrograde conduction through the axillary pathway, thus allowing to set up a re-entry and an AVRT. So this can also initiate an AVRT tachycardia. But important thing to remember is that AVRTs are never on A1V tachycardias. So when we see simultaneous activation of the ventricle and the atrium, AVRT cannot happen, because AVRT, the ventricular and the atria are activated in series. Thus, atrial activation is slightly out of the ventricle, slightly after the QRS. This is the usual rule which we have discussed in the circuit also. So we remember the differential diagnosis of the concentric atrial activation and the eccentric atrial activation. So the differential diagnosis of concentric atrial activation is AV-NRT, AVRT with Parahisian axillary pathway, which is opening near the AV node only, near the His bundle only. The atrial tachycardia, which is arising from that region, or a junctional tachycardia. While eccentric atrial tachycardia, the important differential diagnosis is the AVRT. This eccentric atrial activation will be seen with ventricular pacing. Atrial tachycardia can also have a tachycardia with eccentric atrial activation. In this, ventricular pacing will not lead to the same eccentric atrial activation pattern. And very rarely, in few rare cases of AV-NRT, there may be atypical connection which may give rise to eccentric atrial activation. Another thing to look at is the AAV conduction versus the AVA conduction. So if we are starting a tachycardia with atrial pacing, so what happens in this trace, we are giving atrial pacing through the coronary sinus catheter. We have given a two basal train with 400 milliseconds. We have given two extra stimulus at 240 and 240 milliseconds. So what we see in the second extra stimulus, it doesn't get conducted to the ventricle, it gets blocked. But what it does, it initiates a tachycardia which has an eccentric atrial activation with CS12 earlier than CS910, and it starts a tachycardia which continues. Now the activation of this, starting of this tachycardia is AAV. So the last pace stimulus gives an A, then there is no QRS, it gets blocked into the ventricle, then gives another A, and then starts the AAV induction of tachycardia. So this AAV induction of tachycardia is diagnostic of an atrial tachycardia. Coming down to the tachycardia characteristics. So A1V tachycardia, the differential diagnosis of A1V tachycardia, as we have already discussed, AVRT is out because the two chambers are being activated in series, not in parallel. So the diagnosis is most commonly it would be a typical AV-NRT. Rarely it can be a focal atrial tachycardia where the PR interval is equal to RR interval. Thus every atrial activation of the preceding beat of the next beat is lying on the ventricular activation of the preceding beat, because the PR interval is equal to the RR interval. And the junctional tachycardia, which is a rare kind of tachycardia arising from the junction or the area near the AV node. AVRT is practically out when we see an A1B tachycardia. When we see a short RP tachycardia where the atrial activation is happening outside the QRS, so this can be AVRT, atypical AVNRT, or an atrial tachycardia. This can be anything. When we talk about this tachycardia, if we see eccentric atrial activation, like in this case, it implicates a left free wall axillary pathway, most commonly where the activation is happening earlier at the distal coronary sinus channel. Sometimes we get this kind of activation where the atrial activation is outside the QRS, thus it is a short RP tachycardia. The atrial activation is seen on the coronary sinus channels as well as on his proximal channel. So what we see, the atrial activation is concentric with the earliest at his channel, then the proximal CS, and last at the distal CS. So this can be anything. This can be a conduction through a septal axillary pathway. This can be conduction through an atypical AVNRT, or it can be an atrial tachycardia also. So all three differential diagnoses have to be there in your mind, and we need to differentiate between these three diagnoses. So we have to look what happens spontaneously if there are changes in the tachycardia. So we have to look at the effect of AV block. If the tachycardia continues despite AV block, it rules out AVRT, because AV node is essential. The conduction system is an essential component of the AVNRT. Since it's a part of the circuit, if it gets blocked there, the tachycardia has to stop. So tachycardia continuation despite AV block, most common diagnosis is atrial tachycardia, but sometimes AVNRT can also cause continuation of tachycardia with AV block, and rarely jet can be seen with VA block. So this is an example where when a tachycardia is going on, we see on the coronary sinus channels that there is activation of the atria happening on the coronary sinus channels regularly. There is a tachycardia going on, but what we see in between is that there is a block into the QRS and there is a pause in between. Thus, one of the impulses got blocked and did not travel to the ventricle while the tachycardia continues. So such a pattern of activation rules out AVRT. So the main differential diagnosis here would be atrial tachycardia and more uncommonly AVNRT. But here the activation pattern is eccentric, with the earliest activation of happening at distal CS channel in the CS34. Thus the diagnosis here is atrial tachycardia. It cannot be AVNRT also. One of the important things to notice is what happens with bundle branch block. So often when the tachycardia is SVT is very fast, we might get aberrant conduction in the form of right bundle branch block or left bundle branch block, and we should see what happens during the bundle branch block. This is called as the Kummel's law, the effect of bundle branch block during SVT. So let's consider this example. So there is a tachycardia AVRT going on through the left lateral axillary pathway, where the conduction is happening down through his bundle, through the left bundle, through the lateral wall of the left ventricle, then which goes up through the lateral axillary pathway, goes to the LA and completes the circuit. Now, if due to fast activation, there is a left bundle branch block aberrancy and the left bundle gets blocked. Now, since the left bundle is blocked, now the tachycardia circuit becomes longer. It goes down the AV node, left bundle is blocked, now it goes down the right bundle, reaches the right ventricle, then travels across the septum to the right ventricle and then reaches the axillary pathway. Thus, the circuit becomes longer. Since the circuit has become longer, the tachycardia cycle length will also become longer. So this is noticed as that during AVRT, if there is ipsilateral bundle branch block, ipsilateral means that on the same side as the pathway. For a left-sided pathway, LBBB, for a right-sided pathway, RBBB. So if there is an ipsilateral bundle branch block, it should prolong the VA interval as well as the tachycardia cycle length. If both of these things are happening, the tachycardia cycle length is prolonging and the VA interval is prolonging with an ipsilateral bundle branch block, it implicates that there is an ipsilateral axillary pathway. While if there is no change in happening in the tachycardia cycle length and the VA interval, it rules out an ipsilateral axillary pathway. So if with left bundle branch block, there is no change in tachycardia cycle length, it rules out a left-sided axillary pathway. Similarly, with right bundle branch block aberrancy, if there is no change in cycle length or no change in VA interval, it rules out a right axillary pathway. So this is the concept of Kummel's law or the bundle branch block during SVT. Then we should also look at the tachycardia termination if it is happening spontaneously during the period of the course of the EP study. So this is an example where the tachycardia is going on, where in the first 2 beats we can see there is a narrow complex tachycardia. RV channel is happening with the QRS. Then we see HRA and the proximal coronary sinus and the distal coronary sinus. So this is, it is not, HRA is late, and then the his bundle, and then the proximal coronary sinus and the distal coronary sinus. So this is a concentric atrial activation which is happening along the QRS. So this is a typical concentric A on V tachycardia, which is likely to be an AVNRT, but can still be a atrial tachycardia. But what we see here, there is a spontaneous termination of the tachycardia. And what we see at the last beat where the tachycardia terminates, that there is last atrial activation and then further ventricular activation does not happen. So this is a termination with an atrial activation. So when this termination spontaneously happens with an atrial activation, it rules out an atrial tachycardia. So atrial tachycardia is not dependent on conduction through the AV node. And if the conduction through the AV node is blocked and it terminates the tachycardia, it means that it cannot be atrial tachycardia. It has to be an AVNRT or an AVRT, because in an atrial tachycardia, AV block should not terminate the tachycardia. So this is a very important concept. If we see a termination of a tachycardia with A, it rules out atrial tachycardia and it gives a diagnosis of AVNRT versus AVRT. While if we see the termination of atrial tachycardia, it will always terminate at a V. The last atrial beat of the atrial tachycardia will get conducted to the ventricle, and then the tachycardia will terminate. So this spontaneous termination with a V may still happen with an AVNRT or a AVRT, because block can happen in a retrograde direction also. But antegrade blocking with last beat being A, termination at A, rules out an atrial tachycardia. This is an important observation to be made. Last important maneuvers of today's class is the pacing maneuvers during tachycardia, the ventricular overdriving pacing, and his refractory PVC. So these all maneuvers in itself, one single maneuver deserve a full 1 hour lecture, but I am discussing only the basics and very briefly. So I will be discussing both VOP and the HRVPC very briefly. So what we do in ventricular overdrive pacing, so supposedly a tachycardia is going on, an SVT is going on, we start pacing the ventricle at slightly shorter cycle length, which is 10 to 40 milliseconds shorter than the tachycardia cycle length of the SVT. So supposedly there is a tachycardia going on a rate of 400 millisecond cycle length, and then we start pacing the ventricle from the RV apex at a 380 millisecond cycle length. So it can terminate the tachycardia. If this happens, we have to reinduce the tachycardia and repeat the maneuver. If the tachycardia continues, then we have to see what is happening during the ventricular pacing, and we have to see that response. If there is VA dissociation happening, the ventricle becomes faster and the atria continues on its own rate of the tachycardia rate, there is likelihood of atrial tachycardia. If the VA becomes 1 to 1 during pacing, which means like a tachycardia was going at 400 millisecond cycle length, now we are pacing at ventricle at 380 millisecond cycle length, the atria also becomes at 380 millisecond length, and there is a 1:1 conduction from V to A. If that happens, this is called as entrainment, and we have to look at the response when we stop the ventricular pacing. So once we have done this ventricular pacing for 10 to 20 beats, then we stop the ventricular pacing and look at the response. If the tachycardia terminates, we have to reinduce and repeat the maneuver. If the tachycardia continues, we have to look at what happens at the cessation of pacing. So what is the concept of this maneuver is, so supposedly there is an atrial tachycardia arising from the left atrium from the point star in this figure. So we start pacing from the ventricle, and this stimulus is being given from the RV apex. So when we start pacing from the ventricle, the impulse is faster, it goes back to the conduction system, reaches the atrium, captures the atrium. Now we are pacing, giving 20 beats at this from this site, which is going back to the atrium. Now the atrium is also activating at the cycle length or the pace at which we are pacing the RV. Now when we stop pacing, what happens at the last pacing beat? So last paced beat, it travels back to the atrium, activates the atrium. Now the tachycardia continues. Now since the tachycardia is a focal atrial tachycardia, starts from the star. So now the pacing has terminated. Now the atrial tachycardia starts again. So it starts with the star. So again gives an atrial activation. So the last pacing beat gave an atrial activation, then the tachycardia continues, which again starts with an A, which then gets conducted down to the V. So this is called as AAV activation. If at the cessation of post VOP response, we see an AAV activation, this suggests an atrial tachycardia. While in a case of an AVRT or an AVNRT, what happens is that when we give the last pacing impulse, it is going back to the atrium through the axillary pathway, and then that same impulse, since the tachycardia, the re-entry is continuing, that same impulse travels down the AV node to give the ventricular activation. So it leads to the AV response. So last pacing beat V, then which gives rise to the retrograde A, which again travels down to the conduction system to the V, thus leading to a VAV response. So a VAV response suggests a atrial tachycardia, a VAV response suggests a AVRT versus AVNRT. So this is a very important quick maneuver to differentiate between AT versus AVRT and AVNRT. And this is one of the very important and useful maneuvers which is to be done in every case of SVT to differentiate atrial tachycardia. So this maneuver conclusively rules in or rules out atrial tachycardia. So basically what we are trying to do is rule in or rule out atrial tachycardia. So this is an example. We are doing a ventricular overdrive pacing during the continuation of a tachycardia. So the last stimulus gives rise to a wide QRS, the pace from the RV apex, gives rise to an atrial activation. Then the tachycardia continues, which starts again with an A. So thus giving rise to a VAAV response. Thus this diagnosis of this tachycardia is atrial tachycardia. Irrespective of what is happening, it is concentric, eccentric, whatever it is atrial tachycardia. This is a diagnostic maneuver. This response, last pace beat goes back to the A, goes down to the ventricle, leads to a VAV response. So this is not an atrial tachycardia. This rules out an atrial tachycardia. This is either an AVRT or an AVNRT. In this case, it is more likely to be an AVNRT because the conduction of the atria is happening along with the QRS. So this maneuver helps us to quickly ruling out or ruling in atrial tachycardia, and very important maneuver in electrophysiology. And sometimes what happens is that we are pacing the ventricle, but the atrial activation occurs on its own rate. The atrial activation is not occurring at the ventricular pacing rate. In this figure, what we see in the first beat, if you see the broad QRS, which is the pace QRS, the atrial activation on the CS channel is happening on the earlier part of the QRS, while in the third broad beat, the atrial activation on the CS channel is happening on the end of the QRS, which means the atrial activation is dissociated from the QRS. It is happening on its own while the ventricular is being paced faster. This dissociation is also suggestive of atrial tachycardia. Last maneuver for today is refractory PVC. So to differentiate between atrial tachycardia versus reentrant tachycardia, VOP is important, and to differentiate between AVRT and AVNRT, one single maneuver which is most important is refractory PVC. So what is the concept of refractory PVC? It is very simple. So we give a PVC, we give a precisely timed PVC through the RV catheter in the ventricle at a time when the His bundle is refractory. So since the His bundle is refractory, thus impulse from the pacing impulse from the RV cannot travel back through the His bundle and AV node to the atrium. So if this His refractory PVC is able to travel back to the atrium and change the activation of the atrium, there has to be a separate path of activation apart from His bundle, which cannot be anything else other than an axillary pathway. So if this His refractory PVC can go back, a PVC which is refractory at His, it cannot go back through the His bundle, and if it is changing the atrial activation, it has to go back through the axillary pathway. There has to be a presence of an axillary pathway if it has to change the atrial activation. And in the absence of an axillary pathway, there is no way that a His refractory PVC can travel back to the atrium and change the activation of atrium. So what we check in His refractory PVC maneuver is we give a PVC at a precisely timed activation of His bundle, and we check that is it able to change the atrial activation, yes or no. So how does one determine if a paced ventricular paced beat is His refractory? So if the QRS morphology of this paced beat shows evidence of fusion between the intrinsic QRS and the paced beat, or it is occurring just after the His potential on the His channel, or it is just
occurring between 35 to 55 millisecond earlier than the His potential. So this is an example of a His refractory PVC. Let us look at this example very carefully. So there is a tachycardia which is going on in the first 3 beats, which we see the cycle length of the tachycardia is 295 milliseconds. So we give a PVC which is seen on the 4th beat with a broader QRS and a pacing spike which is seen at the RF distal which is placed in the ventricle. So this pacing spike captures the ventricle, and what we see the timing of the pacing spike at the His bundle catheter, the HH interval is 300 millisecond while the HH interval was 295 millisecond. So this pacing spike lands just at the end of the His electrogram. It is 5 milliseconds after the His electrogram. Thus, this pacing spike is landing at a time when the His bundle is getting activated during the activation of the tachycardia. Thus, His bundle is refractory for retrograde activation. So this HR, His refractory PVC which we have given, captures the ventricle, gives a PVC which is obviously seen at a shorter cycle length, and what it does to the atrial activation. Now we look at the atrial activation in the CS channel. So CS channel atrial activation was happening consistently at 295 millisecond. But after this His refractory PVC, the atrial activation becomes earlier and happens at 235 millisecond cycle length. So this His refractory PVC has been able to change the atrial activation and has drawn in earlier. So when this His refractory PVC has changed the atrial activation, there has to be a presence of an accessory pathway, and it's a diagnostic maneuver that there is a presence of an accessory pathway. It proves that there is an accessory pathway. His refractory PVC can also terminate a tachycardia without conducting to the atrium, or it may also delay the atrial activation. So His refractory PVC cannot terminate a tachycardia or cannot affect the atrial activation, either enhance it, make it earlier, or delay it. Any of the response, any of the changes in the tachycardia with the His refractory PVC is diagnostic of a bypass tract, and if multiple His refractory PVC fail to do this, it rules out at a bypass tract. So this is another example where, and the last concept is VA linking, in which where we look at how the atrial activation is linked to the ventricular activation. If the atrial activation is consistently linked at a secure interval from the previous QRS, the VA interval is constant throughout the tachycardia, that is called VA linking. VA linking is seen in AVRTs and AVNRTs. If the VA interval keeps on changing, it means that the VA linking is absent, and a variable RP or a variable VA tachycardia is more likely to be an atrial tachycardia. So last slide for today, the approach to narrow complex SVT. First, look at the AV ratio. If A is more than V, it cannot be AVNRT or AVRT. It is more likely to be an atrial tachycardia or an atrial flutter. If A is less than V, which is V more than A, it happens only most commonly with junctional tachycardia or rarely with AVNRTs where there is a retrograde VA block. If A and V are equal, that is 1:1 conduction, then we see that is the A linked to V, that the RP interval or the VA interval is constant. If it is not constant, there is no VA linking, it is likely to be an atrial tachycardia. If VA linking is absent, then we do 2 maneuvers. The ventricular overdrive pacing, it helps us to differentiate between a VA AV response versus a VAV response. So it helps us to differentiate between atrial tachycardia and AVRT versus AVNRT. There are certain other features like PPI minus TCL and SA minus VA which can be seen on the VOP maneuver, which helps differentiate between AVNRT versus AVRT, which we have not discussed. While the other important maneuver is refractory PVC. If it changes the atrial activation, it is an orthodromic SVT. Here I end my talk, and this is my last suggested reading. Everybody who is beginning to review concepts in electrophysiology can start with this simple book, which is very simple and intuitive. Handbook of Cardiac Electrophysiology by Murgatroyd. This is a small book, pocket book, and helps us to understand the basic concepts of electrophysiology. And these 3 articles, the diagnostic pacing maneuvers of SVT part 1 and part 2 by Wien-Huizen, and Wien-Huizen one article of principles of entrainment, which was published in IPEJ in 2008. These 3 articles are very helpful for basic reading and basic concepts. Thank you.